where she is.
Hi, everyone. We're so sorry about the delay. We've had a couple of technical difficulties. We will be starting really soon. Just want to introduce myself. My name is Vahed Lokhand, and I'm pleased to welcome you to today's webinar on the treatment and management of severe eating disorders. For those of you who are long-standing attendees of our webinars, welcome back. For those of you who are new to EHN Canada, we are a leading nationwide network of treatment centers for addiction, trauma, and mental health. We offer inpatient services with centers coast to coast, as well as intensive outpatient and virtual options. For more information, visit our website at ehncanada.com. Everyone is on mute and cameras are turned off for today's webinar, but feel free to use the Q&A box to submit your questions for our speaker. We will also be sending a follow-up email in the next week that will contain a link to a recording of today's session as well as access to your attendance certificate. We acknowledge there was a delay in sending out the certificate for last week's webinar, but we will make sure that we have them sent out as soon as possible this time. To stay updated on our future webinars and newsletters, we invite you to opt into our mailing list by filling out a form that will be linked in the Q&A chat. I will introduce today's speaker. Dr. Kalam Sutandar is a psychiatrist at Bellwood Health Services and an assistant professor in the Department of Psychiatry at the University of Toronto. Prior to joining Bellwood Health Services, Dr. Satander worked as a staff psychiatrist in the program for eating disorders at Toronto General Hospital. Her areas of clinical focus are intensive treatment of eating disorders with concurrent treatment of post-traumatic stress disorder and alcohol and substance use disorders. Dr. Satander is also a teacher and supervisor for psychodynamic psychotherapy and family and couples therapy. Again, just want to apologize for the delay in starting, and we are experiencing a couple of technical difficulties, and we're working hard, and our team is working hard in the background to have the presentation on as soon as possible. So thank you all for your patience, and thank you for joining us today as well.
Hi, this is Dr. Kalam Sutandar. If someone can send me some confirmation that you can hear me okay, then that would be wonderful. Sorry for all the technical difficulties, but we will get started. We'll start in slide 2. That's just an introduction of who I am. And we're going to talk today about the treatment and management of severe eating disorders. We'll skip ahead to slide 5, which is the learning objectives. So today we're going to talk about the features of anorexia, of bulimia nervosa, and also binge eating disorder, including comorbidities, prevalence, and prognosis of these disorders. We're going to talk about the components of both physical and psychiatric assessments of people who have eating disorders, and also what are the principles of management and treatment, and what's the difference between management and treatment, both in the community and also in an inpatient setting. Next slide is just a hypothetical situation of a person who may be someone who's in your practice. So this would be a 22-year-old single woman who is a university student who lives with roommates. And she has a 5-year history of restriction, of weight loss, of purging and excessive exercise. And in the last 7 months, she has lost 20 pounds, which has been very concerning for you. Her current BMI, her body mass index, is 16 kilograms per meter squared, which is very low if we consider that what we consider to be healthy is between a BMI of 20 to 24.9. She's had a past treatment history. So she was in day treatment program 3 years ago. Her weight was restored, but she was in partial behavioral remission on discharge, meaning that there were still some restrictive behaviors. Her weight was stable low for 2 years until she had a recent assault. That was 8 months ago, and that precipitated the eating disorder again. She's also complex. She has a concurrent alcohol use disorder. So you're thinking about what do we treat first and how do we find her concurrent treatment? And thankfully, no history of suicide attempts and no past psychiatric admissions. So psychiatrically, a little bit less complex. So let's talk a little bit what eating disorders are. So these are psychiatric illnesses where the symptoms associated have both a psychological and a physiologic impact. People who have eating disorders tend to be preoccupied with their food intake, with their body weight, with their body image. We want to remember that comorbidity in terms of other psychiatric illness is also quite high. So quite high are depression and anxiety, post-traumatic stress disorder, and also substance abuse. And also that there are different types of eating disorders. And as such, you can't look at someone and know whether they have an eating disorder. And each of these different types have implications in terms of treatment, how do we treat it, and also mortality rates. In the next slide, we're going to talk about anorexia. So people with anorexia have a significantly low weight, and this is due to food restriction as well as other possibly eating disorder behaviors. We assess the severity of illness according to what their body mass index or what their weight is. The reason for this is because the lower weight somebody is, the more likely they're going to encounter medical complications and die from their illness. So regardless of other symptoms, we consider mild anorexia to be a BMI of over 17, and then moderate severe down to extreme if their BMI is less than 15. There are the psychological symptoms, so intense fear of weight gain or becoming fat. And there's body image disturbance. Oftentimes when someone has anorexia, they may look at their own self in the mirror and not see the body that you and I see. They may look at themselves and see themselves as being bigger or fatter than they are. Or they may be denial of the significance of the illness. They may say, I understand if someone is at this weight or this, that can happen, that they're too low weight, or they can become ill, or they could die. But they don't seem to be as concerned that this applies to them as other people in their family or their health providers might be. On the next slide, we're going to talk about the subtypes of anorexia. So there is a restricting subtype and there's a binge purge subtype. In the restricting subtype, there is low food intake, so restriction. There's often exercise as well, or what the internet has called orthorexia, people who are very, very concerned with healthy eating, clean eating, and may explain their way of eating because they want to eat clean or eat in a certain way, while believing that this is healthy for them. There's also the binge purge subtype. So here there is binging and more significantly purging. And the reason we worry about that is because with purging comes some of the electrolyte abnormalities and medical instability. So there's binging, there may be vomiting, laxative use, diuretic use. If someone has diabetes, they may be underdosing their insulin or not taking their insulin as a way to not absorb the calories or blood sugar from what they're eating. And this is significant because with anorexia, low weight, if we add binging and purging on top of that, it really increases the medical instability or the rate of death that can happen with that. Then we're going to talk on the next slide about bulimia nervosa. So the thoughts are very similar. The way that someone sees their body, the overvaluation of weight and shape, meaning that weight and shape is the most important thing to me, everything else doesn't matter so much, are very similar. The thought forms are very similar to anorexia. In BN, there is binge eating and compensatory behaviors, and they assign a frequency to this of once a week for at least 3 months. There's a purging and non-purging compensatory behaviors. So non-purging means that they're binging, and the way they are trying to compensate is by using restrictive eating or fasting in between binges, or they may be exercising excessively. If there is purging, it means that they may be vomiting, using laxatives, diuretics, fat pills. Ipecac is a medicine that we used to have that would induce vomiting for people who need to vomit up poison, for example. I think it's really not widely available anymore, but they may be abusing thyroid medication. And so the thing is that people might not recognize that if people are binging and using restriction or fasting or exercise to compensate, we call this non-purging bulimia. If they are using purging, we call this purging bulimia. And then if there is purging behavior and someone is at a low weight, we call that anorexia. If they are at a healthy weight or higher weight, we call that bulimia. The reason being why we differentiate it according to weight, AN versus BN, rather than according to symptoms, because when people are of low weight, that's when they're more likely to die. And so we really want to mark that in terms of severity and what to look out for. In the next slide, we have binge eating disorder. So in binge eating disorder, there is recurrent binging. And again, the frequency criteria is at least once a week for 3 months. And what characterizes a binge is that people may be eating more rapidly than normal. They're eating until they are uncomfortably full and large amounts even when they're not hungry. They're often eating alone because they're ashamed of their binge eating, and they have feelings about it. They may feel disgusted or depressed or guilty. So, for example, if someone goes and has a holiday meal and it doesn't include all of these factors, we wouldn't call that a binge. We just call that, I would say, normal eating, actually, but some might call it overeating, because one may not be eating alone. They may not be eating quicker than normal. They may not be feeling disgusted or depressed or guilty. So there's a differentiation between binge eating and binge eating disorder versus maybe other episodes of overeating. Now, in binge eating disorder, there are no compensatory behaviors. That means that one may be binging, and in between the binges, they are not restricting their eating, or they're not over-exercising, or they're not purging. If they are doing that, we would call that bulimia nervosa. The next slide. So just to recognize that there are other eating disorders, so OSFED, other specified feeding or eating disorder. This recognizes that people may have eating disorders, but they may not meet the strict criteria of AN or BN or BED. So, for example, if one started at a higher weight and they lost a significant amount of weight and are coming into medical complications or impairment, but because they started at a higher weight, their weight is still above or within the normal weight range, we would call that atypical anorexia. If one has the symptoms of BN, but maybe lower frequency, or it hasn't been quite 3 months, we would call that BN of low frequency, or we call OSFED. Similar for BED. And then there are other symptoms of other eating disorders as well that may not be explained by these 3 diagnoses. And in the next slide, other eating disorders also are avoidant restrictive food intake disorder, rumination disorder, and unspecified feeding or eating disorder. I'm not going to talk a lot about these other eating disorders here. In the next slide, we're going to talk about lifetime prevalence. So about 1% of women and about a third of that in men. So recognizing that this happens in both women and men, slightly higher prevalence in women than men. Bulimia, 1.5% of women, about 0.5% of men, and then a higher prevalence of binge eating disorder in both women and men. But these are numbers from 2007. I don't know what the numbers are now. There may be more updated statistics now. And the next slide, we're talking about mortality. So we want to recognize that anorexia actually has the highest mortality of any mental illness aside from opioid use disorder. So this is above mood disorders like depression, bipolar, psychotic disorders. It's because with the medical complications of being very, very low weight, that can cause people to die of starvation, die of cardiac arrhythmias or heart attacks. This is the reason why there's high mortality. Also, the social suffering, psychosocial suffering can cause one to die by suicide as well. So mortality rate of anorexia is between 5 and 20%, higher numbers, the longer a duration of illness. For bulimia, it can be as high as 4%, for OSFED as high as 5%. And then in the next slide, if we're talking about the etiology of eating disorders, what causes an eating disorder, we want to consider and recognize that it's complex, it's multifactorial, and there are biological, there are psychological, and there are environmental contributors. So some of the biological contributors of both anorexia and bulimia. So family and twin studies suggest that there's a strong genetic component. So over 50% heritability. Some risk factors include a family history of obesity, of mood disorder, of substance abuse, and OCD. If there are early attachment and developmental difficulties, so we always do a personal history and find out what was the early life environment like, were there disruptions in attachment with caregivers and family. There are personality traits such as perfectionism, such as obsessionality, excessive compliance, so very people-pleasing, agreeable, and low self-esteem. Being of female gender with exposure to Western thin ideals puts one at risk as well. If there's a lot of weight concern in the early developmental years, as an example, if one is involved in competitive athletics where there's high focus on weight and shape, that can also put one at higher risk. And if there are adverse life experiences, including abuse. Next slide. And then we think about what are some of the precipitating factors. So in the background of some of the previous vulnerability factors, what are some of the precipitants that can then trigger the onset of an eating disorder? So separations and losses, so changes in life, death, disruptions in family homeostasis, so changes in the family environment, new environmental demands. So oftentimes the common age of onset is going into high school or leaving high school, going into the next stage of life, first year university, a lot of changes in what's expected and changes in the environment that can be hard to cope with. Also, direct threats of loss of self-esteem or personal illness. These may be times, for example, in the hypothetical case that I presented, this person had an assault, and then that precipitated the eating disorder. The next slide. Then once one develops an eating disorder, there are also factors that sustain the illness. So there are psychological effects of starvation. When one's brain is starved, it can be very hard. One's brain can become very rigid cognitively and very hard to take in alternative thinking, to think more abstractly rather than concretely, to participate in therapy, to feel emotion. There are distorted body perceptions. So someone who looks at themselves repeatedly, we call that body checking. It's kind of like the way our eyes and our brain functions. If we look at anything long enough, it's going to look larger to us, even if we don't have an eating disorder. So if one is body checking certain parts of the body, it looks large to them, it's going to continue to look larger and larger just because of the fact that you are looking at it over and over again. And then there are cognitive factors that can be related to the disorder. So some of the rigidity, some of the perfectionism, some of the high agreeableness can contribute to sustaining the eating disorder. There are personality features of the individual. So the perfectionism, as I talked about, the agreeableness I talked about, and then continued cultural emphasis, continue to live in an environment where there is an ideal of thinness can continue to put one at risk of an eating disorder. So comorbidity is the norm. What that means is that when someone has an eating disorder, oftentimes there are other illnesses as well. We're looking in terms of high prevalence, there are mood disorders, so depression and bipolar disorder, also PTSD, post-traumatic stress disorder, substance use disorders, many anxiety disorders, including generalized anxiety and social anxiety, OCD, impulse control disorders, and also personality traits such as avoidance, such as obsessive compulsive and borderline personality traits. In the next slide, we have prognosis and outcome. So it's actually important to recognize that most people do recover from their eating disorder. If we look at prognosis of adults with anorexia, 50% have a good prognosis. 60% of people with BN have a good prognosis. The data for younger people is better if they have treatment. This is after treatment. And then again, we talked about mortality and morbidity rate. About 20% of people have a poor prognosis, so severe and enduring anorexia nervosa. And because of that, we know we take very seriously when someone has eating disorder. We really do want to treat it early, but also important to recognize that most people do recover and to give people hope when they come to you. And people sometimes believe I'm always having eating disorder. Most people don't always have eating disorder. They do recover. Next slide is about assessment. So we want to consider this as a possibility, an eating disorder as a possibility in all individuals, regardless of their gender, their race, their socioeconomic status. So it used to be, decades ago, we thought this was something that high SES females, white females have. But in fact, we know that men and women, non-binary, all different races, and people of all different SES can develop an eating disorder. It's really important to ask. If someone comes to you, if you're the primary care provider and they have irregular periods, if there are a lot of weight changes, if they've been dieting, if there are fertility problems, these may be times when they may seek your concern, and it's free to ask about eating disorder. On the next slide, we have a screening tool. So this is the SCOFF questionnaire. SCOFF, each one accounting for a certain question. It's British, you can tell, because for O, they ask, have you recently lost more than 1 stone, which is 14 pounds in a 3-month period? I would say you want to find out whether people have had significant weight loss and find out what that is. Also, do you make yourself sick because you feel emotionally full? C, do you worry that you've lost control over how much you eat? O is accounting for if you've lost more than 1 stone. F, do you believe yourself to be fat when others say that you are thin? F, would you say that food dominates your life? So you would score 1 point for every yes. A score of 2 or more indicates a likely case of AN or BN. And this has a sensitivity ratio of 100%, specificity of slightly lower. So quite high in terms of sensitivity and specificity for screening of whether someone has AN or BN. Next slide is on clinical features, early identification. So many people diet, and we wonder about how do we differentiate if this dieting is concerning or not. So if your dieting is associated with decreasing weight goals, so one may have a certain number as their goal, and once they reach that number, they continue to go down another 5 pounds. And once they reach that number, they go down another 5 pounds. So the goals keep trending down, even though they've reached that goal. That would be concerning. If there's increased criticism of the body, so loss, instead of feeling good about having lost weight, one is increasingly critical about their body and they don't feel good they've lost weight. If there's social isolation, so many of our social activities involve food, and when someone has an eating disorder, they may be avoiding food, and therefore they end up avoiding social activities because they want to have to deal with going to a cafe or a restaurant, having to eat in front of people, or being seen for what they are eating. If one menstruates, then maybe they've lost their period. This is not a highly predictable or reliable symptom. It used to be in the DSM, which is our diagnostic statistical manual when looking at psychiatric illness. We no longer have it there because many people can still get their periods at a very low weight. Many people do not have periods who have eating disorders. And some people take medications that gives them an artificial period, such as oral contraceptives. So it really isn't a great diagnostic criteria. But if someone has lost so much weight that they have lost their period, then we would be concerned about that. And if there's evidence of purging, so many people diet, but purging is never healthy/normal. So if there's any evidence of purging, we would be concerned about that. The next slide, we are talking about assessment. So some of the physical systems, body systems that you might find out about, whether it's affecting our GI system, if they're having stomach ache or constipations. In terms of exercise, if there are frequent injuries or stress factors, and people are exercising despite having fractures, injuries, and therefore not recovering from their injuries. If there is comorbid depression, anxiety, PTSD, alcohol, substance abuse, we might consider whether someone has eating disorder. If people are not improving in their other mental health problems, it's very hard for depression to be treated adequately, both with therapy and with medications, if one is very, very low weight. So if there's lack of progress with other mental health problems, we might consider about eating disorder as well. In the next slide, there's a graphic here about how bulimia affects your body. This is just to show that the being low weight and the effects of binging and purging can really affect every organ system. And therefore, when we are assessing medically, we want to consider every organ system as well. In the next slide, we have treatment versus management. So we want to differentiate when we're helping the person who's sitting in front of us. Are we managing their eating disorder or are we treating their eating disorder? And the reason that this is important is because it helps you to specify what are your goals of care, what are you aiming for here, and then whether or not you're achieving those goals with your patient. And if you're not achieving your goals, it helps you to determine whether they're realistic and not become too upset or frustrated or develop negative countertransference or, maybe question yourself as a clinician. Because when we're helping someone with management of their eating disorder, it's different than helping them with treatment of their eating disorder. And this applies both in the community and also in more intensive treatment setting. So management is when we're providing urgent medical interventions to people who are acutely ill or acute on chronically ill. And the goal of management is to help stabilize them medically or maintain them so that they don't get worse. Their medical condition doesn't get worse. So we're offering them interventions. It might be something like giving them, doing medical management, like checking their vital signs and doing ECGs. It might be giving them IV fluids in the ER if their heart rate is low and the blood pressure is low. It might be giving them potassium if they potassium is low. So this is to help them to medically stabilize and keep them or help them to not get worse. On the next slide, we have treatment, which is different. So treatment is when we are providing comprehensive care, and the goal is to help the person to recover from their illness. This requires more active participation on the part of the patient. It also includes an expectation of change. So we're helping them to recover, and there's an expectation of change involved if we are providing or if the goals of care are treatment. So management should be immediate. If someone comes to you and they're sitting in front of you and they are unstable, medically unstable anyway, we want to start immediately. It might be involuntary. We might be sending them on a form to the emergency department because their potassium is low, because we want to make sure that they're getting an ECG because they have chest pain. So it should be immediate, and it can be involuntary because what you're doing is you want to prevent them from dying. And it should also be the least intrusive intervention that's needed to achieve the goals of management. So I gave the examples earlier of perhaps getting fluid. So sometimes I would say often, like if you're a primary care provider, you may send your patient to the emerge. And then you're frustrated because all they did was give them IV fluids and IV potassium and they sent them home. Well, what they did in emerge was they provided management. They stabilized what was unstable when the patient came in. And once it was stabilized, they sent them home because they weren't providing treatment. They were providing management. Versus, in the next slide, with treatment, this is when the patient is ready. So it requires voluntary treatment when they are ready for change, to actively participate in what is required to change. And it should carry an expectation of ongoing change. So this is different than sending someone somewhere to emerge to be medically managed. In the next slide. So in management, we're thinking about safety concerns, so both medical and psychiatric stability. The medical stability and safety mostly comes in the beginning of an inpatient treatment. Once they've been in inpatient treatment for a number of weeks, usually that stabilizes. Or it would happen as an outpatient in terms of medical management and monitoring if a person is an outpatient and not in an inpatient treatment setting. And then we also consider, so these are physical parameters, we also consider psychiatric parameters such as suicidality, such as self-harm, and such as dissociation. Next slide. When I don't know how many family docs or nurse practitioners or primary care providers we have in the audience, so I just have a couple of slides are about medical monitoring. We do want to do baseline physical exam, including height, weight, and orthostatic vitals. We don't want to have baseline serum amylase. This is to assess for purging. Thyroid function. We want to be aware, though, if someone's very low weight, there's something called sickly thyroid syndrome. They may look like they are hypothyroid, but in fact, it's sickly thyroid syndrome. We don't want to give thyroid hormone because that would increase their metabolic rate and actually cause them to lose weight. So you want to look at the patient clinically as well as looking at the numbers for thyroid function. B12 and iron. You want to then in an ongoing way, you want to monitor their weight, their orthostatic vitals, and their ECG, and then blood work, including CBC, electrolytes, their glucose function, their kidney and liver function as well. If they are in a treatment setting and they're increasing their oral intake, you want to monitor for refeeding syndrome. This is hypophosphatemia that is associated with rapid feeding, and the treatment of that is to supplement with phosphate. And if someone is of low weight, they're at high risk of having osteopenia, osteoporosis. We want to do a bone mineral density scan if they've been underweight for more than 6 months, and we want to repeat it every 2 years if they are still underweight. Next slide. And then the interval between outpatient medical follow-up really depends on your clinical judgment. So the severity of illness, if they're a rate of weight change, a rapid rate of weight change, they can become more medically unstable quickly. So we want to assess more at frequent intervals. If there is a rate of increase in caloric intake, so they're increasing their eating, they can run into refeeding syndrome. We want to monitor more regularly. If there are comorbid psychiatric disorders or medical conditions or complications, we'll want to monitor more regularly. If someone is your patient and they've been chronic for a long time, they may be of very low weight, they may not be purging, or they may not have a change in their purging frequency, you may do blood work a few times, see that there hasn't been much change, and then increase the interval between the times that you may monitor them medically. In the next slide, I just have a few points there about emergency inpatient medical management. So we look at things like rapid weight loss, heart rate and blood pressure, core body temperature if it's very, very low, any cardiac symptoms or electrolyte abnormalities, any signs of kidney or liver failure, if there's decreased level of consciousness or seizures or confusion or severe hypoglycemia, weakness, signs of pancreatitis. Patients who come to you with these signs may need to be certified to be transferred to hospital for emergency medical management, not treatment. And the most common emergency presentation that we see in our settings are hypokalemia, and that can be treated IV or by mouth. Next slide. And then the profile of a patient who at high risk of death. So if someone is at a very low weight, on the previous slide we had said indications for emergency medical management is a BMI of less than 12. If someone is close to BMI of 10, so between around 10 and 11, they're at imminent risk of dying. So we definitely want to get people in a medical setting at a little bit of a higher BMI than that, so BMI of less than 12. If there are multiple purging methods, we're more likely going to run into electrolyte abnormalities, and then that combined with low weight is going to put one at a much higher risk of a cardiac arrhythmia. If they don't have medical follow-up, if they're using Ipecac to induce vomiting, if there's amphetamine or cocaine use that people might use in order to increase their metabolic rate or suppress their appetite, if there is chronic self-harm or suicide attempts, or if their heart rate is very, very low, or actually a lot more alarmingly, very, very high. So when someone comes into a treatment program, or if someone is in an outpatient treatment program, so this is to differentiate from monitoring or management now. What are some of the principles of treatment? So psychoeducation, although psychoeducation is not going to be sufficient in and of itself. Knowing about what eating disorders are and what are the medical complications doesn't necessarily promote change in behavior, but it's still important for people to understand psychotherapy, the educational piece about what eating disorder is and what they can do to their body physically. It's important to have a multidisciplinary approach. So you want to attend to the medical issues. You want to have a dietitian involved to help with the nutritional rehabilitation. You need to have psychotherapists involved to help with the psychotherapeutic aspect of it. Very important for it to be multidisciplinary. And then we want to have medical stabilization. We can't ignore all the factors that we talked about earlier in terms of the different organ systems. The good thing is that if a person is relatively young and otherwise relatively healthy, a lot of the medical issues really stabilize quite quickly when they are being fed. We want to manage medical and psychiatric comorbidities. Nutritional rehabilitation means eating, getting to a regular maintenance meal plan, and then actually probably if they need to restore weight, a much higher meal plan to help them to gain back the weight and get to a healthy weight range. Normalizing eating is non-dieting, so this actually includes people that we're treating for binge eating disorder. If we're using a dieting mentality, it's only going to drive them to binge more. So really teaching normalizing eating, which is all foods in moderation. Some foods you have more, some foods you have less, but we don't have good food, bad food, healthy food, junk food, because those descriptors really only increase guilt and cause people to be all or nothing when it comes to their eating. So it's really a non-dieting approach. And symptom cessation, so offering containment and help to stop from any binging and purging symptoms or any other overexercise or other types of eating disorder symptoms. And then for our psychotherapeutic interventions, we really want to integrate enhanced cognitive behavior therapy. This is CBT that is specific to treatment of eating disorders, so different than CBT for depression or anxiety. We want to integrate DBT, dialectical behavior therapy as well, because if we consider that an eating disorder may be a way to help people to avoid emotions, or they don't quite have healthier coping strategies for managing their emotions, you want to be able to teach people what their emotions are, how to tolerate their distress, how to manage when they're feeling overwhelmed or dysregulated, and what other coping strategies you can use to manage their emotions rather than using their eating disorder. And then there's a lot of evidence for younger people of a family-based treatment approach. We want to involve, regardless of age, family supports when it's appropriate, because oftentimes treatment, if it's at a treatment center, occurs in isolation in a bit of a bubble. And so whenever we involve family support that helps people to maintain that to be well or bring their changes that they've made back to their home environment for them to be well. There's actually limited role for medication treatment in anorexia, and there's some evidence in bulimia and binge eating disorder, and I'll just talk a little bit about that afterwards. So all of that to say is that limited role medication for anorexia, some evidence in BN and BEG, really the principles of treatment rely on the other factors. We want to match the treatment intensity with severity of illness and also the need for containment. So this can range from outpatient treatment to day treatment, which is more intensive outpatient treatment. Maybe there's the treatment team 5 days a week, residential treatment, such as what we have here at Bellwood, and then inpatient treatment, which may be at a tertiary care center at a general hospital. So matching treatment, there are treatment guidelines. APA, New Zealand have treatment guidelines on how do you match treatment intensity. So we would look at severity of illness. If they have very, very severe anorexia, they may need an inpatient setting at a general hospital. Less severe anorexia, still in the severe range, they may need residential treatment because it's just too hard to make the changes in day treatment or outpatient, or the rate of weight change that would be expected in treatment is higher than one can attain in outpatient. If their bulimia symptoms are so severe that there is not enough containment in outpatient or day treatment, they may need residential or inpatient. So really, if we're treating someone as an outpatient and we feel like, oh, this isn't working, it might just be that their severity of illness is so high that they need a higher level of intensity of containment and treatment that we're providing them as an outpatient. Next slide. I talked a little bit about therapy. So we want to help people to prepare for change. So before they come in, and actually maybe even in the beginning stages of being in treatment, they may be here, but they're actually quite ambivalent still. We want to do some motivational interviewing. And then when helping people to make behavioral change, we use CBT principles. So normalizing eating to help them to stop the restriction cycle. We want to help them to decrease or stop with binging and vomiting. As I mentioned earlier, we want to help people to regulate their emotions. So there's a high degree of emotion avoidance or dysregulation when it comes to someone who may be using eating disorder to cope with emotion. So of course, if we're going to take that away as a coping strategy, we need to help people to learn other ways of managing their emotions, and DBT is a very effective method. And then we may use therapy for underlying issues such as addressing low self-esteem, addressing trauma, PTSD, or maturity fears, fears of growing up, of expectations that may be required of them as they're integrating back into the world. We want to help to address that. Next slide is about medication. So food is medicine. This is a great coping self-talk, I would say, that a person might say to themselves if they're really struggling with the eating that they're doing to recover, is to tell themselves that their food is their medicine and they need to eat in order to recover. In anorexia, if we're thinking about medication treatment, we want to consider, is a person eating enough for them to benefit from an SSRI? So oftentimes the first line treatment for depression and anxiety is a selective serotonin reuptake inhibitor. These medications don't give us serotonin. They help us to hold on to serotonin that our body's already made. And our body makes serotonin from tryptophan, which comes from food. So one needs to be eating food to make the serotonin for the SSRIs to work. I don't think we know exactly at what BMI we can use SSRIs and they can work, but certainly if someone is at a very, very low BMI, they're likely not eating enough nutrition for the SSRIs to work. The other thing is that starvation and depression can look very, very similar in terms of the effects of the brain and also how it feels. When someone has AN, they can have an abnormality in their electrocardiogram called a prolonged QTC, and this can be dangerous in terms of causing cardiac arrhythmia. So we want to look out for that. If we're prescribing any medications, that can be contraindicated if they have a prolonged QT or can cause a prolonged QT. In BN, there's some evidence of SSRIs at a high dose. For example, Prozac or fluoxetine at doses of 60 to 100, even 120 milligrams, so higher than what we normally recommended for depression and anxiety. And then we want to consider relative contraindications. So bupropion, Wellbutrin is a medication where if someone is purging, it can lower their seizure threshold, and they may be more likely to have a seizure if they are taking bupropion, and the risk is higher if they're at a higher dose. And also possibly psychostimulants. So ADHD is also something that can be comorbid with eating disorders. However, psychostimulants can sometimes be abused as a way to suppress appetite. They often cause appetite suppression. So if someone is suffering from AN or BN and you don't want to give them a medication that's going to suppress their appetite, that's going to even further get in the way of weight gain. Also, psychostimulants, if there are any cardiac abnormalities, it can be contraindicated, so we want to be worried about that as well. In binge eating disorder, there is some evidence for SSRIs, for topiramate, and for Vyvanse, which is a psychostimulant. So you want to differentiate if someone has BED or they have BN. If it's BN, you want to be more cautious about psychostimulants. If it's BED, Vyvanse is actually indicated for treatment of BED. Next slide. Motivational interviewing. So to help the person in front of you decipher whether they are ready for treatment, you might do some motivational interviewing. The focus is on forcing change, but perhaps facilitating a process through the stages of change. They may be pretty contemplative, and we want to facilitate them to go through to become more contemplative, but go into the action phase. So you might consider them or have them consider what are the costs of continuing with an eating disorder, what are the benefits of continuing with an eating disorder, what are the costs and benefits of working toward recovery, which may overlap with the above two, but may not. And also, what function does the eating disorder play in my life? So one example could be on the next slide, a decisional balance. We want to help people look at the pros of eating disorder or the pros of recovery. This is hypothetical of what we hear from people all the time. An eating disorder might provide them with comfort, can feel like a companion to them. They know it, they know how it feels, so it feels comforting. When someone has an eating disorder such as anorexia, starvation actually feels comforting versus when someone doesn't have an eating disorder and they're very, very hungry, they might get irritable. So it's a different kind of sensation. It may help them to numb their emotions. So being starved affects your brain. You don't feel your emotions as strongly. Also, binging and purging numbs emotions. So it may serve that function as well, which is why we use DBT when we're in treatment to help people to identify and tolerate distress and cope with their emotions. Restriction can people feel strong and in control. It can be an excuse for failure. So I wasn't able to work. I'm not able to go to school because of an eating disorder, not because of any of my own other abilities. It may, if they have diabetes, it may help them to ignore their diabetes. And then examples of pros of recovery, less complications, medical complications, and they might feel better. Their mood and concentration can improve. They may be doing it to get their family off their back. They will maybe have to function better at work, and they may be some pros of recovery. So you want to help people to work through some of the pros of eating disorder or recovery and see where are they at in terms of whether they want to access treatment or where are they at when they are in treatment. We focus on DBT and CBT skills. So that includes eating at scheduled meal times. So mechanical eating on a schedule, not according to hunger cues, because hunger cues are not reliable if we haven't been responding to them for a very long time. So breakfast, lunch, dinner, 2 or 3 snacks in a day. I would say eating every 2 to 3 or 3 to 4 hours when awake would be healthy and normal, and planning the meals ahead of time so that you know what you're eating, you're responding to how you're feeling in the moment, which can cause restriction or cause binging. Exposure to feared foods. So some people who struggle with binge eating might say, I don't want to touch the things that cause me to binge on them. I just want to avoid them altogether. But in fact, that increases the risk of binging, because then when they eat them, if they eat them, they become all or nothing about it. I've already had a bite, I might as well binge on it. Whereas the exposure to the thing that causes anxiety, which might be the feared food, and incorporating it into a regular meal plan helps take away some of the value judgment, calling food healthy food, junk food, and helps you to be able to eat it in a normal way without binging on it. Response prevention means if I feel very, very full, I might normally vomit, but for response prevention is sitting through using skills to address these urges and not vomiting. Or I have high urges to exercise when I feel uncomfortable after a meal, using new skills to not do that. Increasing awareness of connections between your thoughts and your feelings and behaviors. This is a CBT skill. So what are the thoughts that I have that cause me to feel a certain way? And when I feel a certain way, this is how I act. And maybe that way of coping isn't so helpful for me. If I can be more aware of what my thoughts and feelings are, then maybe I can also learn other ways of coping and not using old behaviors. We want to address any cognitive distortions, such as all or nothing thinking or other cognitive distortions that can be associated with eating disorder. We want to integrate DBT skills and mindfulness. We want to understand patients using psychodynamic principles. So I think that if we understand that the history of the person who's in front of us is more complex, and there may be a lot of other underlying factors as well, it helps us to also understand them and not feel frustrated. And family therapy is always encouraged, whether we're talking about family-based treatment or any other kind of family therapy, family meetings, just so to involve the supports of the person who you're working with. And then we want to treat comorbidities. So if there is concurrent substance use disorder, we want to use psychoeducation and DBT and CBT skills, SMART meetings, 12-step meetings, relapse prevention, anything that we would throw at it to also address concurrently substance use disorder. And also concurrent treatment of PTSD. So once one is out in a safer space, they are medically stable, they're eating, we also want to concurrently treat PTSD with psychoeducation, with CBT, DBT. Here at Bellwood, we use cognitive processing therapy to help address what might be one of the precipitating factors of the eating disorder. And then if there is a standalone mood and anxiety disorder, separate from eating disorder, we want to treat that when appropriate as well. So that is the end of the formal part of the presentation. And I want to leave room for questions. If there are questions, I wonder if maybe they can be read out to me and I can answer them that way.
Hi, everyone. Please feel free to put in your questions into the Q&A box, and one of us will read it to Dr. Sutandar and get an answer for you. I know there are some questions about CEU and attendance certificates. Please be assured that we will be sending everyone a follow-up email in the coming week with an attendance certificate, and you can use that to submit to your association for CEUs. And thank you, everyone, for your patience with the technical difficulties we faced today. I do see Dr. Satander is on the screen right now. So thank you, Dr. Satander, as well for your patience with us and the technical difficulties. Yes, so if people have questions, please feel free to put it in the Q&A box. And if for some reason you're not able to find the Q&A box, please put it into the chat and we will try to stay on top of that. There's a question about a recording. Yes, in our follow-up email, we will be sending a recording of the webinar in addition to the attendance certificate.
There was a question here, if you could have a little more information about hypothyroidism. That was one of the questions here. Could you elaborate a little bit on that?
Hyperthyroidism, okay. If someone is very, very low weight with anorexia, they can have CEU thyroid syndrome. Their TSH and free T3, T4 looks like they are hypothyroid. And so if you're not looking at a very thin person in front of you, like if you don't see them and you're just looking at the numbers, you may think that they're hypothyroid and treat them by giving them thyroid hormone. But if they're very low weight, they have anorexia, and that's what's causing the CEU thyroid syndrome, you're going to end up increasing their metabolism because you're giving them thyroid hormone, and that will be contraindicated. So what you do is you don't treat the numbers, you treat the person in front of you who's very low weight by nutritionally rehabilitating them with weight restoration. The thyroid, TSH, T3, T4, it actually normalizes. So basically the bottom line is, don't just look at the numbers of TSH, T3, T4 and think that you have a hypothyroidism and you're giving them thyroid hormone, because that's going to counteract in terms of if they're also in treatment and you're trying to feed them, it's going to ramp up their metabolism. They're not going to gain weight.
Okay, here's one more question. Are there antidepressant medications other than SSRIs that might work with someone underweight?
No. What are you treating? So there are some studies are looking at, other than antidepressants, some studies look at antipsychotics, for example. Are people because olanzapine is an antipsychotic that causes weight gain. So can we use it to help people gain weight? Or can we use mirtazapine, which also a side effect is weight gain? Can we use that to help people to gain weight? It's kind of an artificial weight gain. So when we look at people who are in treatment studies, it initially helps them gain weight, but then at the end of a number of weeks of treatment, the weight is actually exactly the same as people who are not taking mirtazapine, who are not taking olanzapine. So we have tried to use these medications to help some of the like weight gain, but it doesn't quite work. We may use as an anxiolytic. So sometimes I use quetiapine as an anxiolytic because I don't want to use benzodiazepines for that. So for a little bit before a meal to help decrease the anxiety of eating the meal, to help them to get through and have the meal. Those are maybe times when I'd be using some of these medications off label.
We'll do one more question just in the interest of time. Is diabetes a risk factor for AN? Noticing a link between the two in some of the slides.
I wouldn't say that it is a risk factor, but I would say that if you have someone who has diabetes, you definitely want to find out from them whether or not they are using their insulin medication, like their insulin, appropriately. And definitely if someone has an eating disorder and they also have diabetes, you really want to be vigilant about whether or not they are underdosing their insulin.
Okay, Vahed, do you want to do the closing?
Yeah, thank you so much, Dr. Satander, for the informative presentation. We're so sorry, everyone, about the technical difficulties. We thank you all for joining, and we would invite you to opt into our mailing list to stay updated on future webinars. And please expect an email in the coming days from us with a recording of the webinar, which will include the presentation, as well as your attendance certificate for CEU purposes. So thank you very much, Dr. Satander, and to everyone who has attended.